Hi, and thanks very much for joining into this presentation. My name is Rob Fowler. I'm a critical care physician at Sunnybrook Hospital at the University of Toronto, and I'm chair of the Canadian Critical Care Trials Group. And I have the pleasure to speak a little bit about how we are treating patients at the end of 2020 and how we will treat patients in 2021 that come to our hospitals and our critical care units with COVID-19. One of the first questions to ask is, how long will this pandemic go? How many waves will there be? And do these waves really occur? Well, they sure do. In the Spanish flu in 1918, 1919, we saw a series of waves of influenza over a period of really 2 to 3 years, with peaks and valleys corresponding in part to the onset of the outbreak, and then in part due to changes in social distancing, and in part due to temperature and humidity changes in northern climates. And we'll likely experience something similar with COVID-19. We definitely saw waves of another coronavirus outbreak during the 2003 SARS outbreaks in various parts of the world, including here in Toronto where I work. And we saw two prominent waves that year, mainly dealing with the differences in the public's ability to control spread within the community, and then our own challenges in preventing nosocomial amplification in hospital as we admitted patients with SARS. So these waves definitely occur. Other coronavirus infections around the world, for instance, Middle East respiratory syndrome, that has been with us over the last 7 years or so, has seen a number of waves over that time period. And again, similar to the coronavirus outbreak with SARS in 2003, a lot of nosocomial amplification. Spread, of course, animal to person, a little bit person to person, and then a lot of spread person to person when we have people in close confines with each other. And so this is a real concern for us, both in hospitals and in the population. When we look at the epi experience in Canada, we see for sure that we are well into our second wave of COVID-19 in our population. Will this demographic epidemiology change across different waves? That's an interesting thing, because we often see slight differences in who it is that's being infected, and therefore maybe the outcomes of those infections. And I'm just going to go through a few slides. We definitely know that there's an age relationship between patients that are getting infected, but more importantly so, those that are coming into hospital, with older folks much more likely to come into the hospital, both males and females. And we see similar trends in the intensive care unit. Oftentimes, the tapering off at the extremes of life may be due to differential preferences of patients, families, and perhaps within the healthcare system, different approaches to patients at different ages. But there's a clear age gradient between those getting infected and those getting very sick. This carries through, unfortunately, into the patients that succumb to COVID-19, and this has been a consistent story across the world around the oldest patients having the highest risk of death. Now, as these waves progress, and we can even see during the first wave of COVID-19 in the northeastern United States, the ages of people getting infected, at least those being detected in the population, seem to drop as we went further into the outbreak. And this may be because of some changing demographics within those that are susceptible. It may be, in fact, related to differential social distancing and preventative measures that different parts of the population are employing over the course of the outbreak. In the Ontario context, we've definitely seen a drop in the age of patients getting infected over time. And we see here in this graph that at least those that were detected early on, huge spikes with respect to rates per 100,000 of the population in the oldest of age ranges, and that's really changed over the course of this outbreak. What about outcomes that may change over the course of subsequent waves of COVID-19? Well, if we look at ICU experiences in different parts of the world, it's often influenced by the cohorts that have been studied, the eligibility of the studies that are reporting on outcomes, and then sometimes in relation to the specific health systems and usual demographics of patients in the intensive care unit. If we look at the UK experience using the ISARC platform that's been so helpful during the outbreak, we can see survival in the range of about 60% across people that are admitted to intensive care units and followed up for about 90 days. If we look in the United States with, again, different characteristics of ICUs and admission patterns and numbers of ICU beds per patient population, we see ICU survival a little bit differently, maybe slightly higher in a shorter time. And in the Canadian context, again, slightly different characteristics of numbers of ICU beds per the population, and perhaps admission practices around COVID-19 ICU survival pegged at in the 70% range or more in those that receive mechanical ventilation, just a bit more. If we look now again at the age and time frame interaction and how that relates to mortality, it's fairly early on in our second wave in Canada, but we see numbers that are as high as they were in the spring, but a very different on the lower graph story with respect to mortality. And this chiefly relates, I think, to differing demographics, younger people being the ones that are most likely infected in the second wave, who inherently have a much lower mortality rate. It may be that we're treating people different in the hospital, and we'll get to that. And it may be that there's some influence on outcomes in how we're treating those that are infected. But I think the majority of the change in outcomes and the lowering of mortality at the population level is due to the different demographics of people being detected who are infected. How about therapies? At the beginning of this outbreak, we really, of course, had no strong sense of specific therapies because it's a new virus and a new clinical syndrome. We were armed with really generations of knowledge about how to best care for patients with severe viral respiratory infection and viral-related critical illness of a multi-system nature. And we try to promote that we should stick with what we know is best with respect to supportive care, ventilation, all the usual ICU management practices until we gathered more specific information about how to treat patients with COVID-19. The WHO set out a research roadmap to try to help countries and individual groups prioritize what we may focus upon for specific antiviral and anti-inflammatory medications. And this graphic tries to highlight a few of the areas, either specific antiviral targets or perhaps more general or more specific anti-inflammatory targets around SARS-CoV-2 infection in humans. I'm going to focus on just a few medications that have been used and now some that aren't used. So hydroxychloroquine got its start as a potentially promising drug through observational studies that examined those treated and those untreated and clinical outcomes. Unfortunately, as is often the case, it's impossible to really adjust for measured and unmeasured confounders in such a design. And promising early results in observational studies promoted politically as much as medically needed to be evaluated in the context of rigorous clinical trials. While that was being done, we could see a huge spike in use, in particular in this case in the United States, by hydroxychloroquine or chloroquine prescriptions that were dispensed, and shows us the value of being cautious, I would say, in ensuring that medications that we are considering for use clinically have been evaluated with clinical trials as opposed to observational studies. I'm going to focus on a couple of large platform trials around the world. One, the WHO Solidarity Trial, which is now operating in over 400 ICUs, 400 hospitals rather, in over 30 countries around the world. And the Recovery Trial, which has been centered on the United Kingdom experience with COVID-19 and has really been a terrific example of how to stand up a large clinical trial very quickly and with great collaboration across the UK within the NHS system. Back to hydroxychloroquine. Both of these large trials have evaluated hydroxychloroquine and essentially found it to be not helpful with respect to vital outcomes and potentially harmful. We see a point estimate here that's just on the bad side of one, and really we're not seeing this used in hospitals without any evidence base behind it. It's really fallen off. Lopinavir ritonavir is another antiviral medication that had some in vitro and small amount of in vivo evidence to say that it may be beneficial in SARS-CoV-2. A long history as an anti-HIV medication, and was evaluated in a number of small studies and then small trials, showing a bit of promise early on, and subsequently subjected to larger evaluation in the Recovery Trial, finding no impact on mortality at all. And as well in the WHO Solidarity Trial, again, finding no impact on mortality at all, and really is not being used anymore in isolation. Remdesivir is an antiviral that has received a lot of attention and has been evaluated in a very well done trial in the United States, looking at its use in hospitalized patients. And I've put up a series of a number of graphs here from the original publication in the New England Journal on remdesivir that indicate that remdesivir probably by this trial has some influence on the time to recovery, so losing symptoms of COVID in hospital. But with respect to the sicker patients and looking at outcomes of mortality, less clear that there is influence. In a very large WHO Solidarity Trial examining remdesivir, focusing on the outcome of mortality, we really have not seen any influence on mortality in over 5,000 patients randomized to remdesivir or control. And in looking sort of at the patients by their age and severity of illness, we don't see strong signals overall. It's possible that in the less severely ill patients, there may be a signal towards improved outcomes. But this trial is ongoing, and with greater numbers, we may even receive some greater clarity to figure out if remdesivir may influence non-vital outcomes, and potentially if it is differentially helpful in earlier phases of illness, potentially those less severely ill versus later stages of illness. A whole other question that is yet really underexplored is, should there be improvement in time to symptoms? Will this be a cost-effective treatment? And that's something that needs to be looked at over the next months. Corticosteroids frequently used in many conditions of acute lung injury, of viral, bacterial, or other etiology, especially when we really don't have too much else specific to offer. Commonly used at the beginning of this outbreak, again, pulling data from the ASARIC group, looking at all sort of treatments that may have been applied to patients. Yet, based upon the experience with pandemic influenza H1N1 and other viral illnesses, such as the coronavirus with MERS-CoV, there was some concern that outcomes may be worse with corticosteroid use and severe acute respiratory infection because of both influenza A and MERS-CoV, and a concern that there may be prolonged viral shedding. And so with those concerns in place, it was recommended on most early guidelines that corticosteroids be studied in the context of a clinical trial, and they be used with caution outside of that. The recovery trial did just that, and looking at over 2,000 patients with COVID-19 treated with either dexamethasone 6 milligrams daily for 10 days, or twice that many with just standard of care. Terrifically helpful answer in that mortality at 28 days was significantly reduced by, a relatively small margin, but an important margin. And in subgroups of patients, that those that were the most sick might receive the most benefit, and those that were not really very sick at all, perhaps not so much benefit. And so this really been, I would say, taken up and subsequently replicated in a number of other trials, differing smaller sizes, looking at different kinds of corticosteroids, and finding a similar signal to the recovery trial of lessened mortality, especially in those patients that are a bit sicker. And this has really become the new standard of care for patients that are hospitalized and on oxygen with COVID-19. Interferon is another treatment that has been tried in a number of viral illnesses and in acute respiratory viral illnesses. Looking at the largest evaluation to date in the Solidarity trial, we haven't seen an influence on mortality. And if anything, we're worried that treatment with interferon alone may worsen clinical outcomes. And this is a result that's just under preprint and will be sort of fully reported as part of the WHO Solidarity trial over the last part of 2020. If we look a little bit deeper at different subgroups, again, unfortunately, really finding no signal so far that interferon has been helpful. There have been a number of other anti-inflammatory treatments tried so far, not all yet reported, looking at anti-interleukins, specifically IL-1 and IL-6. The background for this is that early on in the COVID-19 pandemic, certainly not surprising at all, we found that non-survivors had generally greater inflammatory markers than those that survived, and again, not at all surprising. When we do comparative work looking at inflammatory markers across different kinds of conditions, COVID-19, sepsis with and without ARDS, cardiac arrest, and trauma, we find that COVID-19 now appears maybe not to be typically characterized by what folks might subjectively call a cytokine storm in relation to many other conditions. And I think that sort of fits with our clinical practice, and that this may happen occasionally, but not as a routine occurrence in most patients. Yet, nonetheless, there have been a number of interleukins tried. Unfortunately, we haven't found a lot of benefit thus far in the patient populations studied, and I'm just going to highlight a couple of trials that are finished up and in various stages of being reported. Tocilizumab received a lot of early attention, but in a couple of trials, the primary endpoints of time to improvement, mortality, and secondary endpoints and others haven't been met. Sarilumab, another a couple of trials just finishing up, and so far in the patient populations studied in hospital and those requiring mechanical ventilation, again, not associated with changes in mortality. How about other antibody-mediated therapy? Well, I wanted to mention convalescent plasma. So convalescent plasma has a long, long history in treating particularly viral illnesses when we don't have any specific therapies to offer. And in trying to pull together studies with SARS coronavirus and severe influenza some years ago, there was a hint that maybe all pooled mortality may be lessened, especially when plasma is administered early. Much of this is not specific convalescent plasma and often uncertain about what titers may or may not exist in individual donated units and transfused units. Early on in this outbreak, there were some uncontrolled and very small sort of case series of patients treated with convalescent plasma, enough that I would say it became a common therapy without a lot of evaluation in some parts of the world. Really incredible sort of programs stood up to administer convalescent plasma, but not maybe benefiting from a full sense of its worth yet. There are a number of trials around the world that are underway. One in Canada is called Concord, and it will aim to randomize 1,200 patients to convalescent plasma with known neutralizing antibody titers for a primary outcome evaluation of intubation or hospital mortality at 1 month. Will also be done with sicker patients as part of the REMAP-CAP trial and in partnership with the Canadian Critical Care Trials Group, and is also being looked at in the recovery trial across NHS hospitals. And so we hope over maybe the coming 2 to 6 months to have helpful data on convalescent plasma. Potential treatment with anticoagulation has been another important area to explore in COVID-19, in part because there have been a lot of case reports of patients with COVID-19 also having concomitant venous thromboembolic disease, and this is an image of one such patient that had large pulmonary emboli. Now, we've seen this before in new forms of acute respiratory viral illness when people are doing CT scans and discovering PEs and wondering whether or not the inflammatory and hypercoagulable state that we see in, I will say, unspecified sepsis carries over in even greater degrees to some of these new viral illnesses. Oftentimes in the past, it's not panned out that it's more common, but we will see with COVID-19. And there are a number of trials looking at usual antithrombotic prevention therapy, prevention in comparison to higher dose prevention or low dose therapy to determine whether or not reducing the risk of clotting is associated with better outcomes in comparison to the potential for increased bleeding. The ATTACK trial is one such trial that's randomizing now many hundreds of patients into a higher versus usual heparin dose arm across the North American context and beyond. And we'll get some answers from that over this next year, we hope. A few other trials to mention. There has been a lot of interest in vitamin C over the past couple of years in sepsis and septic shock generally. One such trial that's been underway has started to incorporate patients with COVID-19 and hopefully will, over the next year or so, be one of the ones that will provide some answers as to signal for vitamin C in this neural infection. Monoclonal antibodies hold some substantial promise as a specific treatment for COVID-19. The science and engineering behind this has improved dramatically over the past half dozen years. And we're starting to see some early evidence from phase 2 clinical trials that are starting out using very specific monoclonal antibodies. There are a couple here listed, one from Eli Lilly and one from one Regeneron, that are under investigation. On preliminary reports, some of the early data from the Eli Lilly monoclonal antibodies hasn't seemed as promising as we hoped. The recovery trial and others are investigating Regeneron for SARS-CoV-2 in a large clinical trial, and it will probably be over the next 6 to 12 months that we have more definitive answers on which, if any, of the monoclonal antibodies may be beneficial for COVID-19. I mentioned that there's promise with this because, in a number of other viral infections that really have had no specific therapy, and in this case, Ebola virus disease, we have seen a number of compounds developed specifically to the virus that have dramatically reduced mortality for patients receiving them. And so we hope that in time we will have similar benefits in COVID-19. How about ventilation therapies in wave 2, wave 3, and throughout 2021? Well, earlier in the outbreak, I would say there was some very important distinguishing of clinical phenotypes of patients with COVID-19. Those that have, I would say, still preserved compliance, suffering oxygenation deficits, but perhaps not so much ventilation failure. Those that had lower compliance, more, I would say, sort of typical mid and later stage ARDS that were accompanied by both oxygenation and more trouble with ventilation. And whether or not we might be able to differentially treat such patients. The decision about using non-invasive, invasive ventilation, high-flow nasal oxygen are all open questions, I would say, and we are still left clinically to make our best judgments on those treatment choices. One of the issues with any of our treatment choices relates to not just the influence on patients and their outcomes, but also perhaps the potential for certain therapies to spread virus in the local vicinity, which may or may not place healthcare workers at increased risk of coming into contact with the virus. And this is just an image of someone receiving high flow oxygen through a simple face mask, demonstrating that at least potentially infectious plumes of exhaled air can move throughout the local environment, certainly beyond sort of 1 meters and 2 meters, and makes it very important for us all in treating these patients to have appropriate personal protective equipment, and including face shields, masks, and N95 or equivalent masks when doing aerosol generating medical procedures. There are a number of places where we can look for up-to-date guidance, both within the Canadian context. The Public Health Agency has clinical management of patients with COVID-19 on their website that is updated on a relatively frequent basis. And the WHO similarly has a process to do an evidence review and to update this evidence review over time. And I would encourage people to look there in addition to evolving evidence that is emerging in our literature and will be promoted in societal websites and documents over the coming months. And with that, I'd like to thank you so much, and appreciate people's tuning in and listening.